Today we are going to speak about gross hematuria in adult. Any patient with gross hematuria should undergo CT cystoscopy, CT urogram, and urine cytology. If CT urogram is contraindicated, then MRI urogram. If CT urogram and non-contrast axial images, CT or MRI. CT urogram is preferred over intravenous urogram because CT urogram has a higher sensitivity and specificity for detecting upper urinary tract pathology. Blood test BUN creatinine test should be checked for patients suspected of having nephrogenic hematuria, such with finding of urine analysis suggestive of nephrological disease. Dysmorphic RBCs cast and proteinuria. Those with medical condition like diabetes, hypertension, checking BUN creatinine should be considered if any patient with hematuria. Consider BSA in men above 40 years of age. Consider CBC, differential count, platelet, PT, BTT, and bleeding time if indicated. Follow-up of patient after negative hematuria evaluation. If hematuria evaluation is normal, check urine analysis within 12 months thereafter. If urine analysis shows no hematuria and the patient has no experience any new episode of gross hematuria, then urine testing for hematuria may be discontinued. If follow-up urine shows presence of microhematuria or less similar degree, patient has no urological symptoms and no episode of gross hematuria, then additional evaluation is needed. If further evaluation is conducted following blood test and other investigation. Urine cytology, especially in patients with irritative voiding system and risk factor for urothelial carcinoma. Ultrasound, CT scan, MRI, retrograde biogram, non-contrast CT or MRI. Repeat cystoscopy. If patient has gross hematuria, a greater degree of microhematuria or urological symptoms, then re-evaluation recommended in like that scenario. Optimal testing regime unknown, however, performing all of the following tests should be considered: cystoscopy, CT urogram, urine cytology, blood test, BUN creatinine, coagulation, BSA, if patient above years of age. Treatment of gross hematuria: treat the underlying cause of the hematuria. Corrected coagulopathy: consider stopping non-steroidal and heparin, warfarin, other anticoagulant. If patient anemic, consider blood transfusion. If bleeding significant, place 3-way hematuria, place 3-way catheter, and irrigation and evacuation of all blood clot from bladder. If bleeding is coming from the prostate urethral, placing the catheter or light traction may tamponate the bleeding and may minimize blood pressure into the bladder. Consider starting continuous bladder irrigation with normal saline. If bleeding persists, perform a cystoscopy under anesthesia.